We are in now active cartilage repair globally for almost last 30 years, where lots of surgeons across the world are doing cartilage repair. But still we are confused between a pure chondral injury, a pure osteochondral injury, and a pure subchondral injury, right? Indian Cartilage Society in India, will you believe it that for many, many years, I was the only member of the society because people will not believe that cartilage can be repaired. And they will say, Deepak will do anything for you, but don't make us a member of this society because cartilage cannot be repaired. Lots of things happened in 2004 and 5 in my life when I developed an active interest in cartilage repair. And when I saw first few cases of osteochondral fractures, literature was talking about bioabsorbable pins and screws.
So welcome folks. Now we are in the brand new series of podcasts and we are looking at the innovators around the globe. And to begin with, we start with the Indian innovators, and we have with us a legendary visionary leader, Dr. Professor Deepak Goyal sir with us. So to tell him, it's a very elaborate and detailed introduction I need to give because it will take a couple of minutes. Please bear with me. Like, he is a faculty visiting like 38 countries. He delivered like 350 lectures. He has around 40 publications in reputed journals, and he authored 8 around chapters. And he has his own book published by Springer, Germany on cartilage repair. He has 2 patents to his name. And like his book on the illustrative book on cartilage repair has over like 12,000 downloads so far. And that book also got the Best Book Award in 2022 from the Bombay Orthopaedic Society. And if we look into that, he is a visiting professor at various universities like Hiroshima University. And he's also got like the prestigious Houston Award from the AOSSM, the American Orthopaedic Society for Sports Medicine. And he is involved in various societies around the globe, like British Association of Surgeries for the Knee and the American Orthopaedic Society of Sports Medicine. He's a fellow with the Asia Pacific Orthopaedic Society of Sports Medicine. And he's also a member of the Education Committee and the member of the Knee and the Joint Preservation Committee of the ISACOS. And he's also associated with ESCA as a past cartilage committee member and a traveling fellow. And he is very much involved in ICRS as immediate past Secretary General and an executive board member. Like, he has a lot of other accreditations and honors to say, and he is the president of Asian Cartilage Repair Society. That is a very honor to us to have him here. And he is also the founder of the society and the past president of Indian Cartilage Society. We have with us a wonderful leader, a visionary, and an innovator who is going to elaborate on various innovations he has done so far. And very welcome, Professor sir, for having you here. Thank you so much for accepting our invitation.
Thank you. Thank you, Satish. Thank you, Team Brew with Boards. It's really exciting to be part of this podcast or this series. I was going through some of the YouTube videos from your channel, and they are really fantastic. So I feel privileged coming here. Just a small correction in your introduction. I did not get the Houston Award, but I was jury for the Houston Award. I wish I get that award. Just a little correction.
Okay,
but it's fine. Yeah. So thank you very much for inviting me. I look forward to the call today, to your questions today.
Wonderful, sir. So, I mean, you are like one of the pioneers in cartilage repair in India,
Yes.
and like a godfather for many of us with respect to cartilage repair. How did it all begin? How did you develop the interest in cartilage repair? We were all looking at ACLs and PCLs whenever we saw the knee, but you had that specific interest of looking at the cartilage. How did it develop?
Thanks for asking this question. Actually, it touches my heart whenever someone asks me this question, because I think it was 2003 or 4, and I was doing good as a general orthopedic surgeon, fixing fractures throughout day and night, and I was looking for something exciting. And then in one of the conferences, I saw someone showing mosaic plastic procedure. And that's what excited me, that I had been in this field by that time, I was already 13, 14 years in the field of orthopedics. And I thought, come on, I never thought of that cartilage can be repaired. And this is something which is challenging, and this is something which needs to be done, because all the time when we see joints with lost cartilage, we just leave it. And so I thought, why not? Why not try this field? And then I developed more and more interest in 2004 and 5, visiting various leaders around across the globe who had pioneered various surgeries like mosaic-plasty, ACI, microfracture techniques, and other neurostimulation techniques. And that's it. More and more, went into, met the people and get into the depth of cartilage repair. It was an exciting journey because I got good results, and I was really pleased to start something new. And then when I came back and I started Indian Cartilage Society in India, will you believe it that for many, many years I was the only member of the society, because people will not believe that cartilage can be repaired. And they will say, Deepak, will do anything for you, but don't make us a member of this society because cartilage cannot be repaired. So it was a tough call, but then finally science prevailed, the truth prevailed. And now you see there are many, many cartilage surgeons in India and across the globe who can do good cartilage repair surgeries, and we can preserve the joints.
Wonderful, sir. That's a wonderful thought, and perseverance of you on the cartilage repair has taken this society to the global arena.
Thank you.
So, more than the cartilage, you are most fascinated about the osteochondral complex per se. So,
Yes.
you are more working on the patellar and its osteochondral complex and the entire area around it. Can you elaborate us on what fascinated you to look more into the patellar biomechanics, the osteochondral complex of it, and its injuries and things?
Yeah, sure. I think there's another exciting question. So first, I will answer the first part of your question about the osteochondral complex. You know, we are in now active cartilage repair globally for almost last 30 years, where lots of surgeons across the world are doing cartilage repair. But still, we are confused between a pure chondral injury, a pure osteochondral injury, and a pure subchondral injury, right? All three are different pathologies. And we loosely use terms like osteochondral or chondral or subchondral while we talk, while we treat our patients, and while we publish in various literature. So somewhere I came across some good papers where they were, specifically talking about the role of subchondral bone in cartilage repair, and that excited me, and that made me think that basically subchondral bone is a healthy soil for the healthy grass or healthy cartilage on it. And then there is an interesting story. I was cruising on river Brahmaputra, that is in Assam, and while cruising, I saw the river bank where there was green plantations. Underneath the green plantations, there were thick sand, the sand just below the grass, and below that there was loose sand. And the flow of the water was eroding the loose sand. And as the flow of water was eroding the loose sand, the thick sand and the plants on it were getting collapsed at different places. And that made me think that if the subchondral bone is not strong, the cartilage cannot survive, as if the sand is not strong, the plant on top of it cannot survive. And that's where I developed interest that to repair a cartilage, we need to take care of subchondral bone. As far as patella is concerned, I can say that patella is another passion of mine, mainly patella instability. And I saw many patients with patellar osteochondral fractures. And way back, around 20 years back, patellar osteochondral fractures were not easily identified. The awareness was not as it is today. So anything which is more confusing, it always excited me because I wanted to go in depth of it and solve the riddle. So that's how my interest in patellar osteochondral fracture started in around 20 years back.
Wonderful, sir. So on the way of solving the riddle, I think you have contributed so much to the patellar literature. Can you elaborate us on the superficial quad technique of MPFL repair that you developed, and what prompted you to come out with a new technique and techniques that commonly used?
Today, you guys have found out all the touchy questions for me. It was like 2004. A friend of mine who was MD physician, and his wife came to me and who had patella dislocation. And very honestly, in 2005, 4, I did not have any idea about all the science behind patella instability and all the biological and morphological abnormalities that can, make a patella more unstable and all the details that I know or we know today. But on examining her, I found out that a medial restraint is missing in her. As soon as I'm pushing her patella, the patella is just popping out laterally. And I thought maybe, why can't we have something which is tying from the medial border of patella towards the inside of femur that can, keep it checked and it doesn't allow it to dislocate. That was an initial, you can say amateur thought because I was not very well learned about patellofemoral joint at that juncture. And then I went and searched for the literature and I found out that there is indeed a ligament called medial patellofemoral ligament, which has already been invented or already been found out by people. And there are various techniques to do MPFL reconstruction. And I said, wow, how backward am I? I don't know any of these things. And then I started searching for which could be the best tissue for that patient, which can help me to put the medial restraint. And while searching through various papers, I came across one anatomy paper where there was mentioning about the rectus femoris tendon, which is a thin strip of tissue. And I thought maybe rectus femoris is very near to patella, and I can, erase it from the quadriceps tendon till patella, and maybe put it on medial side of knee, and it can work. It was a daring for me because I was doing it for the first time, and the patient was friend of mine, and he understood, and he said, "Yes, I believe on your thought, and let's try that." And we did that, and bingo, it was successful. And that's how I developed more interest on MPFL reconstruction. And then I scanned almost every literature that was present at that time, every English literature that was present on PubMed. And then I found out that lots of things are already known to people, and there are many ways to do MPFL reconstruction. But probably I found that the superficial quad, that is essentially rectus femoris, is one of the best way to do MPFL reconstruction. And believe me, since then, I must have done more than 400, 500 cases, and all the cases had been 100% successful. There is nothing 100%, but still I can say because I'm yet to see a redislocation case so far.
That's wonderful, sir. So now
Thanks.
let's shift gears. So that is on the patellar instability aspect and your innovation on the reconstruction part. So coming to this osteochondral fixation. So
Yes.
at the time where you felt that there is a gap in the techniques or the armamentarium to fix or stabilize this osteochondral fractures, what were the options available and what is the gap you felt that made you to invent or you felt the urge to do something more than what is available at that time?
Yes. So I think lots of things happened in 2004 and 5 in my life when I developed an active interest in cartilage repair. And when I saw first few cases of osteochondral fractures, literature was talking about bioabsorbable pins and screws. And that never came to, I could never absorb that because, when you talk about fracture, it's like breaking of bones in two pieces. When osteochondral fractures are not actually fractures, the bone is still intact. The patella is still intact. It is only the surface of patella that has chipped off, right? And I was looking for that there has to be something which is more subtle, which can, will not shatter the fragment. It will not create further complication and still it should heal. And that's where I came across some papers and I thought that maybe suture can be a best option. And that's how, I shifted to sutures. Uh, so there are two presentations I'll share. Is presentation seen now?
Yes, sir. Yes, it's visible.
Okay. So, so if you look at these presentations, there are many papers which talk about fixing the osteochondral fracture with screws, and then they show clinical picture that how the good movement came and patient was happy. But then it shows good fixation. But then they again publish after some time that there were problem. The screw started jutting out. It started creating arthritic changes in and around the screw and in trochlea, and then they were forced to remove. In one of my patients, this was not operated by me, but it was operated somewhere else. And he came with severe pain 3 years after surgery. And what I saw was that the Herbert screw was jutting out of the patellar osteochondral fracture. It had caused severe arthritis around the screw. And he was young patient. I think it was 23 years old patient. And the whole arthritic changes had developed on medial patellar facet. So I had to remove the screw, scrap the tissue, and put ACI. So I feel that screw fixation for the tiny osteochondral fracture or for the chip fracture, there are certain problems. Say, for example, there is 8 mm piece, osteochondral piece. And if you try to push Herbert screw, the diameter of which can be from 3 to 6.5 millimeter with a drill bit requirement of 2.4 millimeter or more, it can very well fragment that piece. Or if at all you put the Herbert screw, it can cause erosion of the trochlear surface or erosion of the surrounding patellar chondral surface. A screw can back out, as you can see on this X-ray, and can become severely painful. The screw head will not allow any cartilage growth at that place and in the surrounding area. And that can be a problem for the patient. If the screw is there, you cannot do MRI assessment whether the fracture is healed or not because it will create artifact. And the screw should be removed because it is interarticular on the cartilage surface. Now imagine a situation, you have put a screw. And now the current guideline says that even in first-time dislocators with osteochondral fracture, you should fix the fracture and do MPFL reconstruction. Now you have put the screw and you have done MPFL reconstruction. Now how you are going to remove that screw? Because you have already closed the medial arthrotomy with MPFL reconstruction. You cannot cut MPFL again for removal of the screw. The screws has many problems. Similarly, if you look for biopins, the loosening has been reported, chemical reaction has been reported, persistent pain has been reported, bone absorption has been reported around the defect, and above all, the biopins doesn't have the compressive strength. It will provide, if you put multiple pins, it will provide rotatory stability, but there is no compressive strength. The screw has good compressive strength and rotatory stability, but the biopins do not have compressive strength. Of course, biopins you don't need to remove, but then there are problems that are reported with biopins as well. So that's where I feel that if we use sutures in tiny chip fractures, it is the best option. So while I was searching for an option, I came across this paper from Aman Dhawan. It was published in Arthroscopy Journal, I think 1999 or something, or 2004, I don't remember exactly, but I think it was 1999. And he had used Ethibond to fix the osteochondral fracture. I was happy that a suture can be used to fix a chip fracture, but I was not convinced about Ethibond or fiber wire because again, it will erode the cartilage surface. So the first patient that came to me, it was really a large fragment. I was not sure what I am doing is right or wrong, but still I went ahead and used polyglactin 910 to fix it. That is Vicary. And I was really dead scared because I was worried that what if the Vicary gets absorbed before fracture unites. But then remember, these patients are usually adolescent patients. They are very young with a very good healing potential. And these are tiny fragments. And again, when you fix it back, the fracture fragment gets compressed between patella and trochlea in all the range of movements. So they healed very well. All the cases which I did, they healed very well. I was so scared that in all these patients, I used to get MRI at 6 to 8 weeks to know what is happening. I have not they separated because of absorption of Vicary or not, but all the cases you treated. And then I grew more confident that the polyglactin 910 is good enough to fix such chip fractures. And then I started presenting my cases in various countries and various forums in Europe, Asia, USA, and even in IPSG meeting also, I presented my case. And colleagues, all the friends, they obliged. They started believing that, yes, a suture is good option to treat osteochondral chip fractures. But then I saw a problem. If you can see on the slides, everybody has his own way of fixing the osteochondral fracture. Every surgeon customized the sutures the way they felt it is fit to do it. So, and then they used to send me the pictures that, we used polyglactin to fix the fracture and it was nicely fixed. And I always thought that there has to be a standardization of technique. There has to be a technique which is uniform across all the countries and all the surgeons. And it should not be that a customization is needed in every surgery. At the same time, there was lots of literature which started coming up after 2017. And every 6 months or a year, there is a journal which is publishing fixation of osteochondral chip fracture with sutures, and they keep on publishing. So it was like, very encouraging for me that sutures are working, something which I reinvented, because I cannot say I invented the idea because it was already there, but something which I reinvented in 2004 and tried to popularize across the world. Now it has been widely accepted across the world, and that is where I get my encouragement. But the challenges which I saw was that there is no uniform fixation method. Every surgeon is doing his own way. There is no way to get the compression of the fragment on the native bed, because sutures are just holding it, but they may not be providing a compression. The needle was difficult to penetrate. Remember, the patella has the thickest cartilage in the body, and the subchondral
Yeah.
bone cortex is also very thick. So it was very difficult to penetrate needle, the curved needle, from the patellar subchondral bone. And it was something like we fear that we might shatter the fragment. And if we over tight the suture, then there is always a fear that it can have a cheese wire effect, because the fragment can cut through the cartilage. And then there is always a universal fear that what if suture gets absorbed before fracture unites? And that led to the sense of insecurity.
So you have listed like the complications behind fixing those trivial osteochondral chip fractures from the patella using any metal screws or biopins, and we saw a list of complications that you have beautifully described and shown, and that is causing a lot of arthritis in those young adolescent populations. So, like, is it only the motivation, or what led you to go behind the sutures and refine it further for making the surgeons more comfortable in fixing those osteochondral fractures? Please share your journey on developing this DG lock for us.
Okay, so it so happened that whenever a colleague of mine or surgeon, he used to share the suture fixation for osteochondral fracture, I almost always tried to call him and try to understand that how he did that, what was the problem he faced. And then I realized that the biggest problem is a false sense of insecurity. The another problem is no standardization of method. Third problem was they were always worried about the compression which is taking place or not between the osteochondral fracture and the native bed. And the fourth problem was the strength of fixation. So I thought that if I can design based on my experience and a device or an implant that can solve, if not all, many of these problems, then probably we can, solve the problem, solve the riddle here, and that can be a one-stop solution for all the osteochondral fractures of the patella. So we started experimenting in my hospital and then in lab. First, we started with wooden blocks, then with sponge blocks, and then we had various options to fix it, like multiple needles, one needle, and then we had tried variety of blocks which are more hard or more soft to mimic the patellar cartilage, subchondral bone, and patellar spongiosa. And then when we had little bit of idea about it, then we finally freezed on two designs. Both the designs had a protection ring, or DG ring we called it. The ring served multiple purpose. Basically, the idea of the ring was that it will spread the force from the center centrifugally and across the periphery of the fracture, so that the forces are spread evenly. The second advantage of this ring was that it will provide a compressive strength, because as you tighten the suture, the forces through the four strands of sutures will go into the suture ring, and the suture ring will indirectly compress the fragment on its native bed. So that was like, transfer of forces, or the centrifugal forces getting converted into the compressive strength. So that was another advantage we found with the suture ring. The third advantage, which was very important for us, was that suture ring was keeping the suture little bit elevated from the cartilage surface. That is important because, as you know, that these osteochondral chip fractures, they are very thin. Sometimes there is just a sliver of cartilage. So if you tight too much, it will have a cheese wiring effect. It will cut the cartilage. So to prevent that cut through, this suturing played a crucial role because the suturing, even though it is providing a compression, it is keeping the thread on top of the suturing. So once it is keeping it on the top of suturing, it is not directly in contact with the osteochondral piece or the thin layer of the piece, even though it is providing the compression. So there will not be any cheese wiring effect on it. And the fourth beautiful thing was that with the help of suturing, we only needed one hole in the center of the osteochondral fragment. 1 2 mm drill hole, that's it. All four peripheral holes are outside the osteochondral fragment in the native crater, but not passing through the osteochondral fracture because suturing allowed us to do so. And finally, with these two designs, we freezed one of the design and then excuse me. Then we need to have the biomechanical testing because we wanted to know the strength, how much strength the construct is providing. And for that, we did the biomechanical testing in the lab. And we were very pleased that the whole construct provided 140 Newton of the force before it breaks. So that was quite a strength for a tiny osteochondral fracture of patella. And we were very happy that this DG lock device and the DG ring both will provide a good strength and it will not just tear off after the surgery.